Thanks for hanging in there, everyone. It's such an honor and such a treat to introduce Dr. Petra Steinbuchel. She's a child and adolescent psychiatrist and clinical professor here at UCSF, serving as the director of the California Child and Adolescent Mental Health Access Portal, CalMAP, a child youth behavioral health initiative, CalHOPE program, powered by UCSF, that is aimed at increasing access to timely, culturally responsive, and evidence-based mental health care within lower stigma primary care settings. She has a distinguished record of providing high-quality clinical care at UCSF Benioff Children's Hospital, Oakland, working in general child and adolescent psychiatry in outpatient and school-based clinics with medically underserved populations, consultation liaison psychiatry, and integrated care models in consultation with pediatricians. She has held several key leadership positions and teaching positions at UCSF. She has led efforts to expand access to evidence-based interventions for vulnerable populations, including developing collaborative partnerships between behavioral health and pediatric primary care providers in medical, inpatient, outpatient, and school-based settings. One of her most exemplary achievements is CalMAP, a pediatric mental health care access program, which is designed to increase timely access to mental health care for youth throughout California's communities, particularly in the state's most underserved and rural areas. The CalMAP team, which includes psychiatrists, psychologists, and social workers, provides no-cost consultation, education, and resource navigation to California primary care providers, managing mental and behavioral health concerns in youth aged 0 to 25. I have to just gush a little bit more. Petra, I know you gave me less, but I'm going to keep going. Originally launched in 2019 as a UCSF Child and Adolescent Psychiatry portal with a $15 million gift from Lynn and Mark Benioff to UCSF Benioff Children's Hospital, Oakland. Its primary aim has always been to expand mental health services for children and adolescents. It has received further support from a 5-year U.S. Department of Health and Human Services, Human Resources and Services Administration grant, and is now primarily funded by the California Department of Healthcare Services. Again, powered by UCSF's Department of Psychiatry and Behavioral Sciences, CalMAP has significantly expanded its reach from my count, and I'm sure Petra's going to give us a current count, with registered users from 44 of California's 58 counties and over 3,300 youth served. So remarkable work. I'm really excited to hear more. Thank you. Please join me in a warm welcome.
Thank you so much. I really appreciate it. And it's great to be here with everyone. And thank you for your patience with the tech challenges, but I'm really excited to share kind of our current state. We've been asked to present at a couple of other grand rounds in the past, and it feels like it's been a little while. And so before jumping in, just wanted to share this quote that's hosted on the National Network of Child Psychiatry Access Programs that I think really summarizes where how these programs work and what the intention is. And this is a quote by Lao Tzu: "If you give a hungry man fish, you feed him for a day, but if you teach him how to fish, you feed him for a lifetime." I think some of these statistics are very well known to most of us, but I do want to point out, in addition to the 1 in 5, or sometimes you'll see 1 in 4 US children having a diagnosable mental health disorder with often a really long lag time between the onset of symptoms and the time to diagnosis. And then that 50% of mental illness starts by age 14, 75% by age 24. That we saw increased rates of anxiety and depression during the pandemic. And these grew by 29 and 27% respectively. And meanwhile, even though primary care providers, in particular pediatricians, are really well situated to be able to effectively screen because they see most kids, especially as they're younger, that they don't feel comfortable delivering treatment, and up to 50% of youth don't receive the treatment that they need. And that some PCPs were found in one of the studies by the Maryland CPAP program to be managing really severe mental health concerns, both with and without additional support from specialists. So we know that this does happen, and how can we kind of expand that? And then top reasons for not accessing care include trouble getting an appointment, the overall cost, and that the services are just simply not available in the area or for the type of insurance that the family has. I also want to point out that often it's poor experiences with healthcare providers that were consistently listed as a top reason why people don't progress in their access to care. And that's part of what we try to do at CalMAP, is help to bridge that gap. So all of these stats resulted in a declaration of national emergency in child and adolescent mental health in 2021. And then later that year, the then Surgeon General issued a mental health advisory in December of 2021 and specifically called out child psychiatry access programs as a way of addressing the mental health crisis. I don't know how many folks are familiar with this feature on the ACAP website, but there is an interactive feature where you can find your state, your county, and look at, how many child psychiatrists are there. Is it kind of within the mostly sufficient supply, which is, as you can see, there are very few green spots on this map, or high shortage or severe shortage, or, many counties don't have any child psychiatrists. This is the state of California. So overall in the US, there are about 11,500 or so child psychiatrists. And in our state, we've got about 1,500. And the ratio is not nearly where it needs to be. And there is a significant number of folks who are expected to retire within the coming years. And within our state, we've got 29% of counties that don't have any child psychiatrists. I do want to point out some interesting statistics in the state. So if you separate out the state into 10 distinct regions, and you look at the percentage of the state's population that is under 18 that lives in that area, and then you look at the percentage of the state's pediatricians, and also the percentage of the state's child psychiatrists, you'll find that mostly in the pediatrician column, it seems to equal roughly the number of child psychiatrists, maybe off by a few percentage points, but generally those are about equal in terms of ratios. However, in terms of the different areas, 3 regions really stand out. One is the Bay Area, and then the others are the Central Valley and the Inland Empire. And so I want to point out that here in the Bay Area, 16% of the population under 18 lives in the greater Bay Area. However, we've got 30% of the state's pediatricians and 29% of the state's child psychiatrists. And then the reverse is true in the Central Valley and in the Inland Empire, where you've got small percentages of the state's pediatricians and child psychiatrists, and then almost double the percentage of population in contrast. So that's important in terms of thinking about our program and how we're thinking about engagement and outreach, because we need to have pediatricians and other primary care providers who are able to do the consultation and provide this type of care. In terms of integrated care models, I know that we've had a number of presentations in this space, but wanted to call out kind of the differences between having on-site, co-located, and or integrated care, kind of in this first column here, and then child psychiatry access programs that are off-site and include usually a psychiatric consultant, a therapist, and or a care coordinator, and then the collaborative care model, which is a much more hands-on combination of on-site behavioral health care managers and then having an off-site psychiatric consultant. And here's kind of another representation of that. So our program falls into this kind of lower level coordinated consultation model that is represented in the second column here. And we're considered a hub and spoke model. Another way of looking at this is looking at kind of a continuum of tech-enabled behavioral health integration. So in kind of this first area here, you have patient-facing technology that's kind of more self-service and doesn't require clinician input. And then in the middle category here is where you see building capacity to treat mild to moderate behavioral health conditions. I think the mild to moderate is a little bit of a misnomer because we know that a lot of people, don't necessarily remain mild, or some people who may be moderate then go into the severe level. And a lot of PCPs are kind of pushed to practice beyond their comfort zone and often address more severe presentations. That said, so we offer kind of this remote telehub consultation, and it's not collaborative care per se, but there are offshoots from this, and this is an area of exploration. We also offer Project Echo, which is, for those who aren't familiar with it, an online virtual learning collaborative and learning community that combines both didactic teaching and also peer learning, often from multiple different geographic areas, that's also facilitated by subject matter experts. And then e-consults are another modality that are often used by people who have some level of sophistication already in managing behavioral health conditions. In terms of kind of the continuum of supports, and also the history of pediatric mental health care access programs, or also called child psychiatry access programs. And I'll describe the subtle distinction between the two in just a moment. These programs are not a new concept. The first one was established statewide in Massachusetts, PMHCAP, in 2004. And then the second one was the Partnership Access Line in Washington State in 2007. And since then, there's been kind of an increasing number of programs that have started through some combination of potentially philanthropic funding, and then HRSA has really gotten behind this concept and has funded more and more programs. And now there's a national network of child psychiatry access programs. And this is kind of a progression in terms of the map. In 2019, you can see that some states had a fully funded program, some had partial. This was an increase in 2022. And then really just a year later, there was another round of HRSA funding, and almost all states had a full program represented in dark blue. And then this is 2025, where we've got just about all of the states except for Idaho, plus multiple tribal nations and US territories that are funded through a combination of HRSA usually and then state funding. And the core features are having access to real-time consultation that's usually by telephone, and that there is a way to help with referrals and resource navigation, because most primary care providers do not want to get in over their heads, and they may be very motivated to care for their patients' mental health needs, but they also feel like, well, what if it's not just mild? What if it goes into moderate or severe, and I don't know how to manage those things? So that part is really, really critical. And then another really key component is having continuing education available, which as much is kind of imparting the didactic information as it is about networking, about establishing credibility. It's usually from an academic medical center hub or a combination of academic hubs. So you have that kind of brand recognition and that trust in the expertise. And then the fourth component, which is what distinguishes the pediatric mental health care access programs from full scope child psychiatry access programs is the ability to have a second opinion consultation that can be either virtual or in person. And not all programs have this additional component. Our program at this time does not, but something that we would very much like to offer in the future. In terms of evidence, there are a number of publications. You can look at the National Network of Child Psychiatry Access Programs website, and there are over 90 publications that are flagged as noteworthy. But in short, there was a comprehensive RAND analysis in 2019 that found that states that had CPAP programs were more likely to, a greater percentage of the population was likely to receive mental health services than children in states without such programs. And then there's a recent publication looking at youth with PHQ-9 scores that either received CPAP consultation or did not. And amongst those who did receive CPAP consultation, they had a higher odds ratio of being prescribed an antidepressant, of having a primary care follow-up visit to monitor the depressive symptoms, and also of accessing mental health therapy than those who didn't receive the consultation. So far, however, we don't have a ton of data around the impact on patient care and direct impact on outcomes. We have a lot that show how much PCPs have utilized. We have a lot of studies showing that people have been very satisfied with the consultation, and there's a lot of qualitative information about how they feel like this is impacting care for patients. But we don't have a lot that demonstrates, direct impact on outcomes. There have been a few studies also looking at family satisfaction, and that has generally been very, very positive. And families feel like these programs really strengthen the PCP's role in their child's care. This is a really brief overview of kind of our funding. We started off with philanthropic funding, and we're able to do site visits to MHCAP and PAL. And just want to give a shout out to Sean May Lee and Michelle Reeder and Brian King, who were a part of those journeys. And then we launched in September of 2019 with our beta site, Bancroft Pediatrics, and then continue to grow and engage partner sites throughout the UCSF network. And then in 2021, we're able to get THCS sponsored funding through Anthem and Beacon to focus on behavioral health integration in the Central Valley. And that was a really informative and helpful initial expansion in an area that was pretty under-resourced and underserved. And then in August, we received our 5-year HRSA funding, which will continue through September of 2026. And then we've got an additional supplemental funding focusing on school-based health center consultation and expansion. And then last year, we were awarded Child Youth Behavioral Health Initiative funding through DHCS. Before sharing more details, I wanted to just pause and take a step back and look at kind of the framework for our program and our program design. And it's really centered in human-centered design, which is a framework that's been applied not just in healthcare, but also in economics and education. And basically, there are these 3 key phases where there's an inspiration phase, an ideation phase, and then implementation. And these 4 guiding principles are really key, and they've kind of underpinned all of our efforts to date. And the first is being people-oriented, really deeply understanding what are the user needs, and then identifying and solving for the underlying problem, ensuring that you're taking a systematic approach and focusing on the end results, and then continuing to iterate and revise and develop. And it's super important before you actually implement to ask yourself, is this desirable? Is it feasible? And is it sustainable? Another important aspect to consider is what is the perspective of a primary care clinician? We have a lot of primary care clinicians who are using us a lot, and they really want to meet the behavioral health needs of their patients. And then we've got many folks who are maybe not as far into that early adopter phase and profile, and more so along the lines of, I didn't go into this, I don't know if I want to do this, this takes more time. So thinking about, do no harm. How can I fill my knowledge and experience gap? We have really late career PCP saying, I feel like an intern again, this is too hard. And then, do I have the time to do this? Can I bill appropriately to capture the additional time that this might take? And then, will I be forced to practice outside of my scope when mental health conditions worsen and I don't have referral options? So that's why that referral care coordination piece is so key. This is a really brief snapshot of kind of more complex than is represented on this slide regarding the plan, Governor Newsom's plan for kids' mental health, that includes the CYBHI as well as some revisions and reworking of Medi-Cal. And in terms of just the Child Youth Behavioral Health Initiative, this is a $4+ billion initiative that encompasses over 20 different work streams. And they're in these 4 key areas here: in workforce training and capacity building, in expanding and strengthening the behavioral health ecosystem and infrastructure, in expanding coverage, and then in raising public awareness and decreasing stigma. This is really briefly kind of what are the different programs within these. And so we're here under the Behavioral Health Services Virtual Services platform, and also as part of the education and workforce training and capacity building. This is a snapshot from the legislation that was written in 2021, and this is kind of the description of our service at that time. That there's a statewide e-consult service that allows primary care, pediatric, and family practice providers to receive asynchronous support and consultation to manage behavioral health conditions for their patients. And so thinking about the human-centered design piece and trying to meet the needs of our key stakeholders that include the primary care providers as key users, and then also knowing, what this kind of long-term model has looked like and how it's been effective, and then also meeting the needs of what is written into legislation. And so the basic bread and butter of our programming is this curbside consultation that we've been doing by phone. And then I'm really excited to share that we just launched our e-consult component too. And we host a number of different continuing education eligible events, including webinars, including a few different Project Echo streams. And then we've done some live trainings and are planning to expand and host more live trainings in the spring. And then additionally, we offer care coordination and resource navigation. Here's kind of a snapshot of the overall CYBHI aims. These are the 7 aims distilled down. And I'll just share about the ways that CalMAP is supporting these aims. Advancing equity, we share about and support evidence-based practice interventions, including use of measurement-based care, ensuring that people are using reading scales and screening tools, but not only using them, knowing how to actually interpret the scores. What does this mean and what do I do next? And some of the widely used screeners and scales in primary care include PHQ-9 scores and ACEs screening, as well as more and more use of, for example, the GAD-7. And it's not just about the score, but what does this mean clinically, and what do I do with this? In terms of being designed for youth and by youth, we do have family stakeholders as part of our advisory council, and we're planning to include more representation from youth voices. And the idea with the program is really to be able to identify needs earlier in life so that we can hopefully course correct and try to prevent longer term, more chronic and severe conditions as kids get older. And in terms of empowering families and communities, we really want to focus on partnering with families, making sure that their voices are heard in treatment planning, and knowing how to collaborate in terms of creating treatment plans, and that ideally people can get the right care at the right time in the right place and then for the right length of time, and not necessarily need to wait a long time before they can go see a specialist, and also not be staying within specialty mental health care for a really long time if they can go back to primary care and be managed there. And then, not that the program is free of stigma, but ideally that, for some people, especially if they're not going to accept a referral to go see, a specialist, that they might be willing to engage in care within primary care, where sometimes, pediatricians, some of them I've known that they have served families for 3 generations even. So they're much more comfortable there. These are kind of our guiding principles. And here's a snapshot of where we are to date. So we started off as the UCSF Child and Adolescent Psychiatry portal in 2019 and have grown significantly since then. And currently we've got over 3,000 clinicians enrolled, and we've done over 6,000 consults on more than 4,000 unique lives. The reason for that difference between the number of consults and unique lives is that we have usually about 20% or so of our consults are for repeat, questions that come up again because some of the youth are more complex and they're continuing to be managed within primary care. And we now have a presence in 48 out of California's 58 counties. In terms of who makes up this, 3,000 or so PCPs, we really have a mix of about a third coming from federally qualified health centers serving largely Medi-Cal insured populations, and then some combination of solo and group private practices. We also have some larger organizations, for example, Dignity Health implemented universal PHQ-9 screening for all adolescents. And so they reached out to us because they wanted to support their providers as they were rolling this out. And so we've enrolled over 800 Dignity PCPs in California. And then we've also got a number of partners at academic and university-based organizations. In terms of who's enrolled, so it's about a third family medicine folks, about a third pediatricians, and then about 20% nurse practitioners. And then the remaining numbers are some combination of internal medicine, OBGYNs, and physician assistants. But then in terms of who actually utilizes, it's about 75 to 80% pediatricians who are making those calls, and then maybe about 15% nurse practitioners, and then the rest family medicine. And we think that this is maybe because pediatricians tend to be, doing more of the more complex presentations when they're working alongside family medicine folks. And there are a number of emerging and or established practice guidelines that really ask a lot of pediatricians, including, not just the basics of depression screening and ADHD, like you might think, but also in terms of, being able to assess for suicidality. For example, pediatricians are being asked to do more and more in the area of autism, including making presumptive diagnoses so that kids can access services. So there are a lot of expectations. And with that, to meet those demands, there's now an additional 4 weeks that are expected within psychiatry and mental health during their residency training. And we've been partnering with a few programs to help facilitate that educational opportunity. In terms of what people are saying about impact on practice, I'm really excited about this slide in particular. because I do get asked with some frequency, or maybe it's just said, are you just going to teach people to prescribe medications? And is that the main function of the program? And the short answer to that is no. We really like to think about things from not just a whole person, but also a whole family and whole community kind of perspective, and that it's not just about looking for a reason to prescribe a medication, but rather that we want to help PCPs use language pearls and think diagnostically. Just joking with some colleagues about think like a shrink. You want to be able to look below the surface of what's presenting in terms of behavior and think about what might be happening diagnostically, what may be happening in the environment that's contributing to a presentation. So I'm happy to say that the top thing here that's shown is my ability to speak with parents and caregivers about their child's mental and behavioral health issues. Second is my practice has made at least one practice level change. And that we've got some examples of that, including La Clínica de la Raza in the East Bay asked for a training to differentiate trauma from ADHD symptoms. And we delivered the training, it went well. And then we learned about a year later that they had implemented across 10 different school-based health center sites a whole screening protocol with tools in every exam room that were helping to take forward the learning that they got from that one event. Here's a little bit of feedback, and this one has to do with being able to access care in a more timely way, and that that has a direct impact on youth. Here's a really brief snapshot of our educational offerings. We've got the Project Echo learning community. We also host a number of webinars on specific diagnostic topics, and then also in the areas of, for example, dealing with bullying, dealing with racism. And then we also have a number of recordings available for asynchronous viewing, and also that are CME and CU eligible. Here's a little bit of feedback. One thing I want to point out is the increase in self-confidence, and the idea that when someone does a consultation, that it's not just about what are the recommendations for that youth in the moment. It's about the learning exchange that happens in that often 15 or 20-minute phone call, and that the takeaway can then be applied to many more youth that the pediatrician or PCP may never consult about, but that they then apply that learning. And you really see this progression over time with PCPs engaging. And the first time that they present, they might have a really more non-specific question. Definitely have heard a lot of, I've never prescribed an SSRI before, what do I do? And, after figuring out whether or not it's appropriate to prescribe anything, then, hearing them come back maybe a couple months later and say, okay, well, here's the, GAD-7 score. And then I also did a scared rating scale. And now this has happened. And, we started the Zoloft at this dose, and now things are going like this. And what do you think? And it becomes kind of increasingly sophisticated with each interaction and consultation. I want to point out we've got a bunch of website resources that are meant to be helpful, and we're trying to push out measurement-based care. We've got all of our common rating scales and screening tools, and then topic-specific information, both for caregivers and for PCPs. In terms of our care coordination, Marielle Ramsey is our lead care coordinator, and she has been providing a combination of resources and then some direct-to-family care coordination when there's really, really high needs. However, we are kind of expanding the continuum of care coordination offerings to now include some self-service options directly to families, some self-service options, including a searchable database for PCPs, and then and then some direct to PCP consultation, because the mental health system of care can be a little bit challenging to navigate, or sometimes a lot challenging. And that'll be available both through phone consultation and soon to launch e-consult care coordination. And then last, we're still going to offer that direct to family kind of higher intensity for families who have really big barriers like language, or they may not have the time or capacity to schedule and follow through with appointments. Another aspect of our programming that I want to point out is that PCPs talk about how this program helps with burnout, and it's through both the consultation and through the learning communities that get established, in particular the Project Echo. So this quote is from one of our longtime users. CalMAP consultation helps address provider burnout so that you can keep your FQHC staff around, which is especially beneficial for everyone. I think if there's a pressure to see volume, you start getting compassion fatigue. You start feeling unsure that you're actually making a difference or how to really do that effectively. Having resources and tools available increases your feelings of confidence and willingness to keep trying and to not just send everybody to the emergency room. It makes you want to schedule that 2-week follow-up appointment and squeeze them in. And then here's a little bit on addressing wellness and burnout through our Project Echoes. We're hearing a lot about how people feel like they have this place to go, and it's predictable, and it's, there's a rhythm to it with meeting monthly, and that they're feeling supported by peers. I'm going to share just a little bit about kind of our school consultation, and this kind of evolved out of some consultation efforts that we did right around COVID, or the start of sheltering in place, and basically, we started off with some needs assessments in local partner school and school-based health center areas, and then have been able to implement both a kind of more personalized menu of offerings, and then also at a broader scale, our education and learning sessions. So we've got a school-based Project Echo, and then we also offer consultation that's de-identified within that. And then we've pushed out, newsletters and various other resources. And then we do have some consultation efforts, in particular with Humboldt County Board of Education, and we're exploring that with other county boards of education. So here's kind of a snapshot, and then here is a little bit more in this space. And if folks want to check out what's more on our website, it's at cal-map.org. I also really want to point out what's been super fun to see, grow and develop more over the past few years is our different training opportunities. We really hope that the folks involved will just continue to make programs like this better in the future, that they'll be comfortable with doing this type of consultation. So we have had now for, I think, 2 years, child psychiatry fellows rotating through CalMAP, and that's hosted by Dimitri, by Ann, and by Becky. Thank you. And then pediatric residents, we're hosting children's Oakland residents. We've got a UCSF adolescent medicine fellow, and then we're developing more and more for a partnership with UCSF Fresno that will also include getting their attendings on board with doing this work, because if we're consulting to residents and then their attendings aren't comfortable, then they may or may not implement those recommendations. And then we've got some growing opportunities with Cottage Health pediatric residency in Southern California, and also UCLA. And then we've been hosting social work students who contribute a lot. and also medical students, and then master's in public health students. In all of this growth, we are trying to be mindful of how do we need to evolve and adapt, with the times, and so, thinking about kind of where's our sense of purpose. We've always been really mission driven, and try to recruit and hire folks, not just our faculty, but also administratively, who are motivated by the mission of the program. And then adaptability has been so key, given kind of the different needs of our different stakeholders. And that's a really key lesson learned. And we're very relationally driven. Relationships are really at the center of all of this, because that word of mouth recommendation, between PCPs, between our partners, is really critical for our growth and sustainability. So in terms of, lessons learned in this process and in our application of human-centered design, we've got these guiding principles about being people-oriented and having the relationship and also the trust that you are, consulting with an expert, that this is a trusted resource, that these resources that we offer have all been carefully curated and vetted is really critical. And then also being able to do that word of mouth kind of sharing that happens between different organizations is really key. Being able to solve for the underlying problem also has required some innovation, some creative problem solving, and flexibility and adaptability in terms of meeting needs. We've definitely seen an evolution of, initially with the pandemic, there was just kind of, a shutdown. We can't learn anything new. We can't do new workflows. And then, of course, this kind of increased need of behavioral health concerns that were presenting in primary care. And then people feeling like they didn't have the tools, to manage that. So they were very interested in engaging with us, and also with, more people using virtual ways to connect. It really helped to facilitate that. And then we saw this high need for 2 to 3 years. And now I think some of those high needs of kids have maybe tapered off and gone back to more kind of pre-pandemic levels. However, we need to find new ways to meet people's needs. So we're hoping that things like the e-consult consult model, with kind of its more ease of use and faster accessibility, will help to meet the PCP needs. And then teamwork, can't understate the importance of teamwork and being able to be inclusive in our teams and value everyone's input. And then focusing on the end results and ensuring that we've got sufficient accountability throughout. So in terms of next steps for us, we really want to grow, and we also want to be able to demonstrate evaluation of impact. These are the tiers of annual consults that if we push through and get to the next tier, then we're able to continue to fund more growth, which will include also expansion at partner satellite sites. So these are the numbers that we're trying to go for. And here are kind of the main objectives under that, increasing consult volume. So we're developing and launching our version 2 and version 3 of our platform. And this is going to include, new features like being able to upvote and downvote certain content, being able to bookmark it. We just launched our e-consult feature, and we'll plan to be testing out an ability to text and then also potentially do asynchronous video consultation, just to help in terms of ease of use. We'll be engaging in developing our partner sites and then also marketing much more heavily, including our in-person trainings that are coming up. I also really want to recognize and underscore the importance of quality assurance and give a special shout out to the folks who have been involved in that, including Eileen Wang and Yanni Rowe and Jim McCracken. And that we'll need to continue to double down on that as we're just expanding to other sites so that we make sure that we're aligned and following evidence-based practices that are consistent. Here are some additional features that we've talked about. We're wanting to integrate expertise of our partners. It's really exciting to hear new ideas. We just started with our UC Riverside child psychiatrist colleague, Tosha Yamaguchi, who has been sharing really great ideas for having, even 5-minute video pearls that are, teachable moments. And she's got some experience doing a podcast, actually. So eager to learn more. And let's see. So our phase 1 expansion is going to include UC Riverside, who's already started with us, and then also Children's Hospital of Orange County, and then Smart Care, which is located in San Diego and is sponsored by Vista Hill. And we're eager to get started with them and had our first in-person meeting together about a month ago. In terms of outreach and who's our target audience, so people who are eligible for the service are primary care physicians who are treating youth aged 0 to 25 in the state of California. And then we've got various organizations that we're engaging with and want to focus on individual and group practices, on federally qualified health centers and rural health clinics, and then also special emphasis on school-based health centers, on medical groups, hospital networks, and care organizations, for example, Dignity Health, Providence, Kaiser, and then academic medical centers and universities. And then we also have relationships with numerous professional medical organizations, including the California Medical Association and importantly, the American Academy of Pediatrics, amongst others. In terms of demonstrating meaningful impact, we have a number of reporting requirements on, key metrics and that are both for HRSA and for DHCS. And then we've been able to develop some key performance indicators, which I'm going to share in just a moment, in partnership with DHCS and Mathematica, who's doing the evaluation for the overall CYBHI. And then we also want to pursue our ongoing performance improvement processes, and then take that evaluation further. That will help inform our reach and also how we're implementing, and then what are the potential impacts in terms of patient care and patient outcomes. And of course, all of that will help us to demonstrate impact and hopefully sustainability. And I don't know how well folks can see this, but basically these key performance indicators are in the areas of user engagement, for example, consult satisfaction scores, different types of consultations by not only the PCP type, but also by the type of consultant requested, and then as the mechanism, phone consults, e-consults, and then in terms of accessing resources, we have a lot of resources. We continue to publish more, and then we've got a number of page views already, especially for certain training and education sessions, and then in terms of training and skills development, how many providers are participating and claiming credit for those. And then in terms of equity and access, we are looking at, the number or percentage of Medi-Cal insured patients that are consulted about, and then how many consultations are emanating from HRSA designated rural and underserved areas. And here are some proposed potential impact evaluation measures at the PCP level, at the health system level, at the practice level, at the patient and family level, and then also for clinicians in training, and then for insurers and specialty mental health. And some of these are more distal. For example, looking at changes in PCP prescribing patterns and referral patterns. We are starting to see some increased coding for F codes or primary psychiatric diagnoses. And then ideally longer term, we would see changes in referrals for behavioral health emergency department visits and psychiatric hospitalizations, linking back to the quote that was shared a little bit earlier about, people feeling like, okay, maybe I can manage this within primary care as long as I know that I can consult again and that I'll have help accessing other parts of the service. And then in terms of measurement-based care, we are also seeing an increase in consults that come with at least one already completed rating scale before initiating the consult. We had about 19 or so percent presenting with an already completed rating scale in our first year. And then by our third year, we saw about a little bit over 40% coming with an already completed rating scale. I'm mindful of the time and wanting to leave a little bit of time for questions, but there are so many people to thank. I want to give a really big shout out and thank you to our sponsors, our amazing team members, our advisors and champions, both within the department and across our system, and our phase 1 partner sites, and then our really extensive and amazing advisor group and our CYBHI partners and school-based partners. And here's a snapshot of our team. Here's another one. I'm going to pause there.
Thank you, Petra. This is beautiful, comprehensive, rich presentation and work. Really extraordinary. I have a question. When you have PCPs calling in, and I imagine some questions are complex, others are more basic. And when you talk about evidence-based practices, like how long are these calls? And what's the expectation in terms of implementation? Like, are they asking like, how do I do PCIT? Or are they asking like, how do I do a little bit of like thought challenging? Or, if you could give us a sense of that.
Absolutely. So the majority of our calls go to the psychiatrist, and then we do have a strong and growing number of care coordination requests. We've been trying to be careful with, not with finding a balance there, because we're never going to be able to meet everyone's care coordination needs and wants. And then we also offer specialized psychology consultation in some distinct areas, including early childhood, autism, substance use, and ADHD, mood, anxiety, and then eating disorders. And, the majority of PCPs, they want to learn some maybe brief therapeutic skills, but they don't, they're not going to be the ones to deliver that. So we have also a therapy skills echo that teaches kind of, brief therapeutic skills that you could do across a lot of different situations, including in a 15-minute office visit or, in a school setting if you're a teacher or a school-based therapist. But the average call length is 18 to 20 minutes. And then definitely there are some outliers, especially if somebody has a little bit more time. We get a lot of calls on Friday afternoons. Thank you, Jim, for staffing during that time.
Fridays and on full moons, I'm sure.
And it's when people want to tuck away, for the weekend and get their questions addressed so they don't have to worry about their patient. Yeah. But we don't do as much in terms of the, therapy components, but we have other ways of teaching that.
That's fantastic. We have more questions, but it's 1:00. I want to respect everyone's time. Thank you so much for being here and being part of our community. So it's not like we can't reach out to you. So thank you so much.
Thank you. And I was feeling like, gosh, there are so many areas here that could, do their own whole hour session. So maybe we can have team members who present on their areas of focus.
I like that idea. And putting it in my pocket for the next round. I appreciate that. All right, take good care.
Thank you
Have a
so
good
much.
afternoon, everyone. Bye-bye.